Did you guys get any alert that this is recording or anything? Okay, cool. So I guess next, let's go with Kia. Can you introduce yourself, please?
Hi, my name is Kiara Saifi. You can call me Kia for short. I'm a student physical therapist at the University of Michigan Flint. Fun fact about me is I love cats, and another fun fact is Dr. Yusuf and I actually tore our ACLs around the same time, so we were going through that at around the same time, and it was is yeah. But anyway, I'm just trying to learn as much as I can, you know. I'm in my first year, second semester, so I'm just trying to learn.
All right, thank you, Kia. And then Daniel.
Well, yeah, I'm Daniel. I'm a physiotherapist that finished this school in the UK, and I'm in the process of doing my licensing here. I'm hoping to write the exam in May, depending on just the regulatory body and how fast they process that. I went to school in Edinburgh, which is the capital of Scotland. Fun fact about myself is I also really enjoy soccer. I play as much as I can, and I watch every weekend. And then what am I hoping to get from this is just kind of get like a multidisciplinary, multi-point view and discuss and kind of triage and kind of work through cases together, get different perspectives, and just enhance the clinical reasoning and whatnot for me to apply in clinic myself.
Okay, thank you, Daniel. And Thomas.
Hi guys, I'm Thomas. So I'm like a newcomer to Canada. I'm coming from Hong Kong, and I was a registered physiotherapist that have already practiced in Hong Kong for like 2.5 years or something. I used to practice at public hospital in a clinic setting, so kind of more or less like a physio flow. I also have some exposure in medical ward, ICUs, those things. Yeah. So I'm also undergoing the credentialing process, and I'm going to take the licensing exam for the physios in upcoming, I think in May. So yeah, so all the best for Daniel too. And fun fact about myself is I really like long distance hiking. Before I came to Canada, like last August, I spent almost 2 months hiking in the US, and I did around 1,300 kilometers of hiking within that 2 months. So it's a tough experience, but it's fun. So the things that I hope to get out from this is I would like to learn more different perspective from like different discipline, or even we are physios, we may have different point of view. So I would like to try to reduce the professional isolation, especially if I'm going to practice in like a more private setting, like a clinic. I will have little time to talk with like someone from my own profession, so I may get really tunnel vision on something. So having these kind of discussion like once a month will definitely stimulate my thinking even more. Yeah.
Thank you, Thomas. Somebody just joined. I don't recognize that name. So, okay, Nathan, are you available to introduce yourself right now?
Yes, I do. Although I cannot turn on the camera because my hairstyle, I'm just woke up. Prefer
No
not to
problem.
turn on the camera, which makes my life easier. So this is Nathan. I'm also from Hong Kong. Actually, I went to the same physio school as Thomas. We were the same cohort. So I was also a registered physio in Hong Kong, spending around 2.5 years in Hong Kong, but a little bit different settings with Thomas. I also stayed in a public hospital, but then I switched my setting to private clinic, some nursing homes, something like that. And after that, I relocated to Canada, and now I'm working in VIP healthcare clinic, kind of in the western part of Toronto, like Western and where is it, and Wilson, something like that. But I was working there as a resident physiotherapy. So I'm going to take my licensing exam, the second one, in early March. Currently, apart from working, I'm doing a master through distance learning also in Scotland, but not in Edinburgh, in Dundee, so which is a little city in Scotland. So the course is about biomechanics, motion analysis using Ficon. So I'm not sure whether you guys are familiar with that, which is a technology thing which we use to analyze the movement of human, or literally any movable bodies. Like a cat, we also can use Ficon to analyze its motion. I really like the biomechanics part of human movement, although it's not going to explain all the problems that a person is suffering from, but it gives a really objective and logical impression on what's going on. So I kind of I'm quite obsessed with that, and I wish to make more sense out of it. Some fun fact about myself: I was a lover of running. I like long distance running, not a marathon, but I did 10K in Hong Kong. My PB is sub 15 minutes, so not super fast, but I enjoyed the sports a lot. And now I'm struggling a lot in Toronto. How do I resume this sport? How do I run in a cold, in snow? So I know Jason is also a big fan of running, so probably I will ask him some tips about that. I'm hoping to get what I'm hoping to get from this kind of discussion is that I find my way of practice is consistently changing. I'm always trying some school of thoughts, and after maybe a few weeks, a few months, I find it not working very well, and then I switch to the next. I would like to, through discussion, know more about some other ways we can practice and get the best from it, and combine different ways of practicing and find the best for myself. Yep, that's it.
Awesome. Thank you for logging in early in the morning, Nathan. And for sure, I'll give you some tips on how to get used to the cold. I didn't used to run in the cold as well until 3-4 years ago when COVID started. There's not much you could do other than just go run outside. So yeah. Next, who is VHCV South? I have no clue who you are. Can you hear us?
Hey, Dr. Jason, it's Inigo.
Oh, hey.
How
Okay.
you doing?
All right. Good. Can you introduce yourself and just follow this format?
Oh, okay. My name is Inigo, and I am currently a resident physiotherapist, awaiting for my exam. Also, I am a former colleague of Dr. Jason and Nathan as well. I went to school from Philippines. I graduated my bachelor's degree there for physical therapy. And fun fact, I enjoy lifting heavy weights and listening to heavy music. um, what are you hoping to get from this? Uh, more evidence informed practice. I hope to refine, especially my words and how I try to tell it to my patients. Yeah, always a work in progress. So, and also even for topics that I think I already know. I think it is also best to get through it again, just to remember and how to present it to our patients again. Yeah.
Okay, perfect. And thank you, or Inigo. He goes by Ino. So I guess next, Mo, are you available to talk now, or are you busy as usual? I guess he's probably busy doing something. Okay. I guess I'll introduce Mo a little bit. So correct me if I'm wrong. Mo, he's a licensed physiotherapist. Then he got his license a year ago or 2 years ago. So he's practicing at Physio Flow. We do have overlapping shifts, so we often talk about patient care. We have plenty of debates on various topics. He's not a big fan of Adam Meekins, and I am a big fan of Adam Meekins a year ago. Okay, thank you, Mo. And let's see, fun fact about Mo. I know he's a man of many talents, had lots of tools and gadgets, I guess. And I don't know what he's hoping to get out of this. Maybe a little bit more debate with me and with the rest of us. But I think the common theme that I hear is that everybody here wants to learn, are very open to learning, and not only from your own colleagues, but also from other colleagues who are from different, I guess, disciplines. So that's great. And I think, I guess I haven't introduced myself because most of you guys know me, but my name is Jason. I'm a chiropractor. I practice at Physio Flow with Dr. Yusuf, Daniel, Kia, Thomas, and Mo. And then I practice at VIP Healthcare Clinic with Nathan and I actually just started working at a new clinic in Markham just on Mondays. Haven't seen a single patient yet, but tomorrow I'm going to see my first patient there, who's actually the owner of the clinic. So no pressure. Fun fact, most of you know I play tennis, I run. I've been to every continent of the world except for Antarctica. And what I'm hoping to get from this, and of course, similar to what you guys are hoping to get, is to learn from each and every one of you, and also just challenging my own thoughts and beliefs because I have my uh, experience and learning, but it could be biased, it could be very biased in certain areas. So I want to sort of challenge my biases. Also, I do have probably out of all of you, I have the most clinical experience because I've been a chiropractor since 2015. Been working just in rehab since 2009. So I want to share some of my experiences with you guys, some of my clinical knowledge, area expertise, and yeah. Other than that, I think last time we talked about some sort of ground rules or expectations. Give me 1 second here, guys. So I just want to go over these again quickly before we move on to the next portion. So again, of course, we're here to learn, and we're all experts in our own fields and ways, and we're unique individuals. So we may have different opinions. So we need to respect one another, even if we don't agree with somebody. So for example, me and Mo sometimes would disagree with each other. However, we could come off a little bit blunt or aggressive. At the same time, we never call each other names. We never use vulgar or profanity for one another. We still respect one another. So therefore, try to reserve your judgment until you have a deeper understanding of a certain topic, or at least have a deeper understanding of what the other person is trying to say. And also just try to come from a mindset of curiosity rather than judgment, and just don't take things too personally or too seriously, because at the end of the day, me or each one of you, we don't matter that much in the grand scheme of things. We're just individuals. Also, when things potentially get heated, or people are disagreeing with one another, remember why we're here. We're all here to learn. And then you want to challenge yourself to think critically and question everything, but of course you don't want to question everything to the minute detail. You want to think sort of to a certain level of detail, but also think of the overall big picture. And over here, of course, we do not condone any personal attacks, any sort of racist, sexist, ageist, homophobic, transphobic, xenophobic, discriminatory, non-inclusive, and extremist remarks. Anything else from you guys in terms of like some of the rules that we should have, some of the housekeeping things? Anybody? All good? Okay, cool. So I guess for today, I could either present something I presented a few years ago. I think Daniel, you were there at PhysioFlow when I talked about tightness, right?
Was that in that was in person, right?
That was in person, yeah.
Yeah, yeah. I remember that. Yeah.
You remember that, yeah. So it might be a little redundant. So I could do that, or I could pull up this 14-minute video on nociceptive, neuropathic, and nociplastic pain. So the 3 general types of pain by Dr. Andrea Furlan. She's I think she's a physiatrist practicing, or pain specialist, maybe probably a physiatrist practicing in Toronto here. She has a PhD in U of T. So let's put it up to a vote. How many of you want to watch the 14-minute YouTube video and then we'll talk about it openly? And how many of you want me to present my previous presentation? So let's go YouTube. Who wants to watch that first? Anybody? Nobody? Okay, so I guess everybody wants me to present, I guess. Yeah. Okay. Cool. Right now, let's see. It's 8:57, so we'll have about half an hour. So somehow I'm running out of time. I think we're just gonna cut it at 9:30 just to respect everybody's time. Again, this is not a big deal. So anybody have any question at the moment before we proceed? Okay, cool. So let me share my other slides here. And feel free to like put up your hand through Google, or just unmute yourself and interject at any time. If you have any questions, or if I'm not being clear with anything. And everybody, oh no, sorry, 1 second. Technology. Can you guys all see this? I can't see you guys, so that's 1 second.
Oh, good. I can see
Yeah.
it.
Yeah, okay, sounds good. Thomas, give me 1 second. Let me just from beginning. Okay, you guys can all see it, right? Okay, so the title, Demystifying Tightness. So I actually presented this October 17, 2020. I actually didn't have time to change anything. So some things may be not super up to date. So how do I proceed to the next slide? Okay, so first the learning objectives. By the end of this session, you should be able to describe what tightness is, and then you should be able to compare and contrast flexibility and mobility, and be able to differentiate between passive care and active care. When I gave this presentation before, just toward some of the assistant and practitioners, including massage therapists as well. So their understanding of these topics may not be as in depth as chiros and physios and naturopaths. So I think probably most of you can differentiate between the two in terms of passive and active care. So I might not go too in depth. So now this comment, I have tight traps. When patient grab their upper traps. How many of you, show of hand, have heard of this line from your patients before?
Always for those neck pain patients.
Yeah, I have tight traps. So what do they mean by that when they say tight traps. Do you guys have any sort of input? Is it a shortened muscle? Is it just a sensation, or is it something else? Any ideas, guys?
I would rather say it is a sensation of soreness or tenderness that they perceive.
Mm-hmm.
Yeah, I was
Anybody
gonna say
else?
more like I guess like discomfort in that area. Maybe
Mm-hmm.
not pain specifically, but some sort of
Yeah.
discomfort.
Yeah, absolutely. So can we measure this tightness? Is it a problem? And what should we do about it if there's anything we could do about it? Anybody?
I mean, there's no real way to measure, I guess, like a subjective reading, right? Because we can't go into their issue and take like a direct measurement. So can't really, everything is basically self-reported. So
Yeah.
we can't really measure self-report.
Yeah, I definitely agree. If it's something that's very subjective, it is very difficult to measure. So now I do have some, again, these are just some of my thoughts based on my knowledge and maybe some things in the literature, but there could be some objective findings such as decreased range of motion. Somebody's tight when they turn toward the contralateral side. If the right side is tight, of course, your range of motion could be limited. And you could have myofascial trigger points. Now, I guess there's some controversy with that as well, and whether or not actually it exists. Also, in terms of measuring it, we could use things like visual analog scale, which is self-reported, or a numeric pain rating scale, which is also self-reported if they have that tightness, pain, or discomfort. Also, there may be altered EMG readings for somebody who has some extra tension in their muscles, I would assume. And I think there's probably some literature that supports this idea as well. So I guess from my perspective, again, I could be very biased. Tightness is a sensation that may have multiple causes or contributing factors. It is not purely objective. Of course, we'll all sort of agree so far, and may or may not have any palpable findings like a trigger point. So there have been moments where, let's say, patients say, hey, this is really tight, or I poke around over there, I don't feel any extra tension. Maybe their other side that's asymptomatic could feel tighter to me. And of course, with this tightness, usually they still have some sort of range of motion. Perhaps it's limited. So we could use, let's say, a goniometer, measure the range of motion, compare side to side to see, okay, neck lateral flexion toward one side is, let's say, 25 degrees, and toward the other side is 40 degrees. So that gives me some, a little bit more clue. Other than that, I think when we're dealing with tightness, I think when we're talking to patient, instead of focusing on that subjective feeling of tightness, or even telling the patient, oh yeah, your muscle is really tight, and validating them, which we should, I think we should focus on finding out if there is motion or enough motion, and of course if they're able to function with or without that sense of tightness. So in terms of function, okay, I forgot I went ahead. So first of all, is there movement? Is there motion? And how much movement? Hence, you can eyeball it. You can use a goniometer. You can even use your iPhone. There's a app that you can use to measure the range of motion as well. And then the quality of movement, which consists of speed, control, maybe even power or strength, and there's any compensation of the area around it. For example, if they have that tight upper trap, if they laterally tilt their head, their shoulder, scap, GH joint may all start to elevate, which may indicate some things, I guess. And also we want to know, does that motion relieve or aggravate the tightness? So a lot of times, when we have that upper trap tightness, I guess previously I used to tell patients, not so much anymore, I used to tell patients to stretch that. So a lot of time people do get that relief from stretching it. However, there are plenty of patients that actually get more aggravated when you ask them to stretch it. So sometimes we may have to get them to go in the ipsilateral side to contract that muscle to get some relaxation, possibly after the contraction. Or you do something called pills and rails from FRC. We can talk about that at some point in the future. So how do we improve motion and function? Any idea, guys? Anybody? You know?
Well, I probably would start with what the patient can do and look for any limitations. So I most likely would start my patients with uh, yeah, we can try stretching, active range of motion, and then to see if they can push it a little bit more. And yeah, most likely those things, if it's tender, you know.
Yeah. So you're talking about exercises essentially.
Yes.
You're doing some active rehab or stretching, which yeah. What else? Kia, what can we do to improve motion and function if they have that tightness or limitation? Sorry, I'm putting you guys on the spot.
Maybe we could do some myofascial trigger point release, or maybe some cross friction massage to get some neuromuscular effects in there as well, so we can possibly improve range of motion that way.
Yeah, some manual therapy like soft tissue therapy, right? Whether it's ART, MRT, or whatever technique, Graston instrument assisted, or sometimes maybe even acupuncture or whatever, taping, right? Which, you know, the efficacy probably not as good, but yeah. And then lastly, as I guess, oh yeah, I guess none of you are chiropractors here. I'm the only chiropractor. So something like spinal manipulative therapy. So, well, some physio can do it. Like I think Mo is trying to get rostered. Yes, and Mo, yes, I see your comment here. PNF, I don't know what MET is. Yeah, so those are, I guess, different types of exercises. So great. So you guys are definitely on the right track. So first, SMT, spinal manipulative therapy, that's something that I do very often with patient. Soft tissue therapy, again, something I do often with patients. And then rehab exercise, which I'm sure we all do with patients. Okay, so that comes down to my next point, which is passive and active care. I'm sure all of you know what the differences are. I'm still going to go through this table. So passive is something done to the patient. The patient is still, they're not doing anything. They're just lying there, sitting there, maybe standing, whatever. So the body is reacting to it. Usually the effects are temporary, or at least relatively temporary compared to active care. And active care is something more dynamic. Patient is involved with their care. It could you could incorporate various positions, whether sitting, lying, standing, crawling, jumping, kneeling, whatever it is. And the body is initiating the care rather than receiving or reacting to the care that's being done. And typically, active care has longer lasting effects. So now my question for you guys is, why in general is active care a little bit more long lasting compared to passive care? Anybody want to honest? You don't, again, guys, don't have to answer if you don't feel comfortable, by the way. You can always say, hey, Jason, I'll pass.
I would say because the patient for say the tightness on the context of tightness, like the patient is doing the motion, it's himself or herself, and then he try to like push with limit by limit, push herself. Okay, I can do that. I can do that even larger motion, and to a point that they push that limit to like a normal range, what we call. So I would say because the active care kind of letting the patient like like bringing her ability back, bringing her function back. So like a normal patient without any like psychological issue will quite benefit from the active care because they know they can benefit. They know when they move more, actually they can recover from it. So I would say that's why the active care usually is more longer lasting, actually more effective than passive care. Yeah.
Yeah, I think the key point which you brought in is that there's increased self-efficacy and increased confidence that patient can do those things. They're not as weak as the chiro or physio claim they to be. And also, I think definitely Daniel and Nathan brought up some good points of promoting self-management. Right, you can't do a lot of the passive care on your own. Whether it's modality, whether it's somebody has to stretch you, whether it's acupuncture, patient can't do that at home. Versus you involve them with some active care, they can do those exercises themselves at home, and that leads to consistency and more productive work. Also, with active care, there's the cardiovascular, psychological effects as well. Hopefully, so those are great answers, guys. And I guess when I was making the slides here, these are some of the main differences that I thought in terms of neurology, I guess. And passive care, the stimulus is yes. So there's a stimulus, and that gets transmitted to the mechanoreceptors at the upper tract, and then that signal goes to your central nervous system, and then your central nervous system processes that signal, and then it decides what to do to that muscle. That's essentially passive care. And active care, I think the direction of the signal will be a little bit different. So first, your central nervous system decides to send something to the body to actively move it, and then there's mechanoreceptors here picking up signals, and then it goes back to the central nervous system. So there's more signals involved, so learning will occur as well. So that learning could be just your muscle getting used to, like what Thomas said, with those movements, and then that gradual input, that gradual exposure to the stimulus, to nauseous or uncomfortable with the feelings will slowly get better. Any question at all with what I just explained, guys? Yeah, and again, this is a very simplistic explanation. It's not too. I'm sure there are a lot of nuances, different various pathways in our body that it doesn't work just as it's going up or going down in terms of signaling. But overall, this is a great diagram to depict. Passive care is really easy. Patient doesn't really have to do anything. They're just being massaged, they're being rubbed, they're being stretched, they're being lasered. Versus active care, it is a lot of time not easy work. However, that's our job as clinicians to make the patient feel that it's not that difficult and they can do it. So that's the benefits of active care. So just empowering the patient. How are we doing with time? Okay, we're actually pretty good. So this is another sort of graph I kind of made in terms of active and passive care. Passive care being the initial stage, you probably want to use a little bit more, relatively speaking, but even then, you probably could involve some active care right from the beginning, especially when you're dealing with acute pain. Of course, when you become subacute and chronic, a lot of the passive care, like the modalities, probably will not be that effective. So that's where you continue with the active care and continue to empower patients, continue to promote movement and motion. And now here, I guess it's a pretty sudden jump to the next topic, which is flexibility and mobility. However, they are actually somewhat related to the previous topic of active and passive care. So can somebody describe the differences between these two terms? Anybody? Nathan? Any idea?
So it's like a testing of memory. You told me the answer before. Not necessarily the answer, but you really shared with me the
My
thoughts.
perspective.
Yeah.
Yeah.
I think I've really pretty much the same impression as yours. Flexibility is what we have structurally that is more passive. You can maybe someone can straighten their elbow. I mean maybe it's like hyperextending a fingers. A finger. So flexibility is you can push your finger back all the way towards the end range, and that a big art of movement is what you get in terms of flexibility. But mobility is with control. So you actively extend your finger, but to not to an extent that you can extend your finger by a passive force. So I think that the main difference is having the control or not.
Yeah, no, I think that's an excellent description. So definitely one is something that you can actively control, which is mobility. Flexibility is something you passively you can get the range, but not necessarily you can get there with your own muscles. So this is my sort of synthesized definition or difference of the two. Flexibility is the amount of tissue that can lengthen and stretch. So that's limited by the specific tissue, whether is your joints capsule that's limiting you, or that's the tissue like the upper trap example. For example, if I take my neck all the way, chances are I can stretch it pretty far. However, when I actively tilt, I might not be able to get as far as when I stretched. So this is as far as it can go, lateral flexion. However, I can probably stretch myself a little bit more. So that's the difference. The mobility is the active movement that you can give a body part or joint throughout that range of motion. So again, we mentioned that the flexibility is passive, and therefore it's not that it's useless. I probably should put that in quotation marks, but it is somewhat not very productive in terms of how we move, because if we cannot access that part, we cannot actively access that, it's essentially useless range because we can't control it. So a good example is, for example, if I can actively get my neck to, let's say, 45 degrees over here, and I can control my motion coming back. So if whatever trauma I get or whatever sport contact or just movement that I do, if that's within that range, chances are I'm okay because I have active neurological, neuromuscular control. However, if something pushes me beyond that range, I'm not used to controlling or moving within that range, then there's a higher chance for injury. And therefore, flexibility, we can't really control it. We cannot really train it. Mobility, we can actually make productive changes to it. So mobility would be useful range. So how do we improve mobility? We can't simply stretch because, like we talked about earlier, stretching generally is still somewhat passive. And based on research, stretching only gives you really temporary improvement in range of motion. Again, when you're stretching, you're not really, you don't really have any active neurological drive to the tissue. So how do you guys think we could do to improve mobility? Anybody use this? You have any input?
Yeah, maybe I guess like working on like weekend muscle to just strengthening those muscles so it helps you to go through range of motion.
Yeah, absolutely. Training muscle through your full range of motion, um, strength training definitely could potentially improve your mobility. Anybody else?
I would say not focusing so much on the muscle rather than looking at the joint and looking at degrees of freedom of the joint and working through the full range of motion of the joint. I mean, I feel like it's very unlikely that there will be a muscular limitation in terms of strength. It takes very little muscular effort to go through a range of motion. It's more of the actually gradually exposing yourself to new ranges and then I guess because you haven't been in that range, kind of strengthening yourself into this new unlocked range through gradual exposure.
Yeah, yeah, I think definitely. I think you touched two different things. One thing is the joint, right? The joint could be a limiting factor. If the muscle was in limiting the soft or muscle or soft tissue structures are limiting factors, then we can definitely work on those. However, if the joint is the joint capsule is the limiting factors, then there are different ways to target that. And also, we talked about graded exposure. Yeah, if it's a range that you don't have control over, then you want to gradually work into that range, so full range of motion or lengthen partials. I'm not sure if you guys are familiar with that. Those things are things that could improve. However, the thing about mobility that I didn't talk about earlier is that first, sure, it's the active range. However, within that range, you still need to develop a certain amount of strength, which is a control part. I guess we'll kind of talk about it. So you need good range and good strength. Then you become truly mobile in terms of mobility. Now, I don't think you guys been exposed to this. One second here. However, I have been. So, in FRC functional range conditioning course, I think I probably mentioned to quite a few of you about this course. Something like pails and rails, progressive and regressive angular isometric loading. These are essentially a couple of isometric contractions in the opposite directions that actually is really productive in terms of improving your active range of motion. However, there's no research on specifically pails and rails because the course is based on existing research on isometric contractions, and then they put together a system. So nobody studied this new system that somebody developed. So of course there's no research, and who's going to study it, and where's the funding coming from? So of course, again, there's no existing research. But if you look at research on isometric contractions and range, sort of neuromuscular training and things like that, you can probably get a lot of information on why or how these things will work. So again, when I gave this presentation previously, I've demonstrated in person how this works. So I guess I'll kind of explain a little bit. First of all, do you guys know what this is? Okay. And okay, so pails and rails is essentially it sounds very complicated, but it's not. So for example, well, backtrack a little bit. With that neck, if I'm limited in lateral flexion, you guys can see me, right? Yeah. So if I'm limited in lateral flexion, if my discomfort or tightness is felt on this side, the open side, that's a open angle pain. Versus if I laterally flex, if my pain is felt on the ipsilateral side, that's called a closing angle joint pain. So that joint, these joints are closing, the angle is becoming smaller. If the pain is there, that's more of a joint capsular problem, a joint problem, versus on this side, more of a simple term muscular problem. So if it was only because of that muscular problem, I don't have pain on the ipsilateral side, only on this side, contralateral side, then I would only use a Pale's contraction, which is essentially PNF. So I take my neck to that side, I stretch it, and I contract against this side for about 10 seconds. Because I'm not really moving, when I'm contracting, these muscles are tensioning. And as soon as you relax, you stop tensioning. Guess what? These muscles actually start to elongate or lengthen. Not because the tissue actually grew in length, it's because the nervous system actually told muscle to relax. Thus, you will get slight more increased range of motion. So that's how we deal with open angle pain or more muscular, neuromuscular type of um, limitation. However, when we work on, if my pain was on this side, it's a joint capsular problem, then we will want to use pails and rails. So I would take you to end range. If this is painful on this side, I would not progress further, even if I have range, because we may irritate that range. So we want to stay in that position, in a tolerable position. You would do the pails as the first 10 seconds, similar to what we did previously. However, the second contraction is where we try to contract further toward the painful side without adding too much pressure. So when you're spending more time under tension in this area, you actually start to get used to that. And again, you could use that pails and rails contraction a few times. Then you will actually get some relief symptom-wise on this ipsilateral side. And that's how you increase your range of motion. And also, there are times where you might not get pain, you're just limited. And if you feel that limited or restriction on this side, again, pails and rails is the sort of one of the better solutions for that. Any questions? Yeah, and I think I've demonstrated this on comments. Have I shown that to you before? Maybe not. Maybe not. Maybe, I feel like. Anyhow, yeah. So if I see some of you guys in person, I can demonstrate that, or you guys can YouTube this pails and rails. A shoulder is a really good one with internal rotation. You have probably seen me doing some of these on my Instagram as well. Okay. Other than that, I think this kind of comes down to the last bit of this presentation, which are, a couple concluding takeaway points. So tightness in general is a sensation. It's not always accompanied by objective findings. We want to shift the focus to, instead of the feeling, to motion and function. And of course, generally speaking, active care is better than passive care. And also focusing on mobility, using the right movement or exercises gives you a way better return on your investment in terms of flexibility training, or maybe people call it static stretching training, or even foam rolling. Because if you're given this amount of time, you better do, especially when patients are paying you big bucks for it, you better use the most productive things for that patient. Otherwise, again, this is my perspective. My perspective is that otherwise patients are really wasting their money on you. Again, there is definitely still room for passive care or passive stretching. It's just that I think to be the most effective or most efficient, we want to shift toward more of the active things that we do with patients. Other than that, there's some just resources. These are not my references. These are some resources from my professional association regarding helping patients to do some more active, dynamic things. But again, you can see with some of these, there's some hockey stretches, running stretches. So these are probably some static stretches that one might recommend to patients. Other than that, these are some, I think, clinical guidelines on how to manage certain types of pain. If you have a question about management of injuries. Other than that, I think that's pretty much the end of my talk for today. Let me just get out of here. Do you guys have any questions so far? Any just general input, any feedback for me, or feedback about the material, or anything that could be improved on, anything that you liked about it?
I would say it's a good reflection on what's the meaning of tightness. Yeah. So it's kind of every day we hear this term from either our patient or we say it ourselves, but we sometimes don't really know what's the core of it, or we haven't think about how deep the meaning of tightness is. For example, like core strengthening. So you tell your low back pain patient, okay, we go on core strengthening, and then what is core? Yeah. So it's also a good things to think about. Yeah.
Okay, cool. Yeah, some feedback. Thank you, Thomas. And I'm just reading some feedback from Mo. Level COC1, C1, C2 would be the opposite of lower cervical with lateral flexion. Is it true? I'm gonna have to review my anatomy. So I'll get back to you on that, Mo. And the introduction was too long. Perhaps it could be shorter, and more of that time can be used for discussion. Well, Mo, this is only your first time and also our second time. So a lot of us are not familiar with one another. So I think it's important for us to introduce one another. Could it be more concise? I mean, I don't want to cut anybody off. So, but definitely thank you for the feedback as well, Mo. Other than that, let's talk about, because we're right 9:31 now. I don't want to take too much of everybody else's time. I want to talk to Rachel about when she can present. I think possibly next week. Would you guys all be available next week? If not, then is there another week that would be good for you guys? Again, this is not mandatory at all. If you're not available, it's not a big deal at all. So yeah, everybody's okay with next week, tentatively speaking. Okay, sounds good. And Nathan, you're good? Yeah, Nathan, don't worry. We'll fill you in whenever. So yeah, Rachel is going to talk about lumbar stenosis next time. I'll talk to her exactly about whether it's next week or whatnot. But yeah, thank you guys for participating in this. I'm not sure with the recording if I'm going to post it on social media. Would you guys mind at all? Okay, cool. And Nathan, Mo, you guys are okay if somehow I post this on social media? Okay, cool. Alrighty, well, thank you everyone. Have a good night. I appreciate you guys for joining, and until next time.
Okay,
Thank
thank
you,
you.
Dr. Yusen.
Bye. Thank
Okay.
you.
Okay.
Good
Bye.
night.
Take care, guys. Bye.
Bye.